My name is Anil Lalwani. I am professor and vice chair for research in otolaryngology, head and neck surgery at Columbia University Medical Center in New York City. I've been practicing for about 25 years in all aspects of otology and neurotology. When I first started practicing in 1994, we could only implant profoundly deaf individuals. We didn't know whether patients were going to do well or not. So you didn't want to take people who had hearing and implant them and not know that they're going to do better than they were before. Now we're implanting patients who actually have significant residual hearing. And the reason we can do that is because the outcome after cochlear implants are much more predictable. That is, if you have a patient who's wearing a hearing aid and they're only getting 30% of the words right, they're struggling, their quality of life is poor, they're not able to communicate with their children, grandchildren, or their friends. They're avoiding parties and so on. We know today, in general, for any given patients, they're going to do better with a cochlear implant in that situation than they would with a hearing aid. There are criteria for cochlear implantation, and those are important. You want to assess the patient's functional status with respect to their hearing. How are they performing, are able to hear at work, at home, in social environment? How much are they struggling? I think those are all important considerations in addition to what's on paper about their hearing. How well the hearing aid is working for them is also a very important consideration. Do they feel like they're not able to focus on other activity as a result of having to focus on hearing is another important consideration that, along with their audiological findings, are things that I would look at. You know, I recently had a patient who's in the mid-50s, still working, and though this doesn't happen very often, was in tears in the office because he was struggling so much to hear. And everybody that he had seen basically said, no, there's a little bit too much hearing left. You're not really a cochlear implant candidate. And he felt sort of helpless. Here he was, yes, I have hearing. Yes, you know, I may be getting a certain number of words right, but I'm not really able to function. I'm depressed, I'm not able to work. And I must admit, when a patient by criteria is an offense, you have to think really long and hard about whether you do offer something that potentially has a possibility of losing hearing, whether they have, and the function may be poor. But after a long consultation and discussion, informed consent, all that, we decided to proceed with a cochlear implant. And you know, he did, as we expected, remarkably well. His quality of life was much improved. He was struggling less. One of the things that we forget is when we have normal hearing, our active listening is almost passive. We don't have to spend energy doing it. But when you have a hearing loss, when you struggle with just understanding conversations, you're spending a lot of energy throughout the day with actively hearing. So by the end of the day, you're exhausted. You're not really up for going out and socializing. You're not up to be entertained for all the other things that add depth to our lives, give meaning to our lives. You're not up to having more conversations at a party at home after hours. So that implanting somebody who's struggling but may have more hearing than you normally would implant can be life transforming.